Yes, Ganesh, we can proceed.
Yeah, I being a moderator of today's webinar series, myself Dr. Ganesh Prasad Mudraje, psychiatrist from Puttur and chairman of IMA KSB Harassment Committee member. I am very happy to welcome all the dignitaries who are all the participants of this webinar series. I first of all I welcome our President Dr. Venkata Chalapati sir, our Secretary Dr. S.M. Prasad, our IMA Psychiatry Cell Chairman Dr. Karant sir, and I also welcome IMA KSB's think tank and immediate past President Dr. Madhusudan sir to this webinar series. And I also welcome from NIMANS, there are two important luminaries who are giving a lot of inputs, scientific inputs to this webinar series. Dr. Suresh Budamat and Dr. Yan Manjunath sir, who is today's resource person. And I also welcome today's chairperson, Dr. Kasturi madam, who is around here. And of course, this webinar series is mainly in association with the IPS KC, IPS Karnataka chapter, and Dr. Somshekar Bijal is conducting, and he is taking a lot of enthusiastically, he is taking a lot of um, action in this regard. And everybody knows without participant this webinar series program will not be successful. So I wholeheartedly welcome all the participants. Before giving chance to the today's resource person, Dr. Manjunath sir, I would like to introduce him to the whole gathering of this webinar series. Dr. Yan Manjunath sir is an associate professor of psychiatry and currently working in NIMANS. He did his MBBS from Bangalore Medical College, and he finished his DPM from NIMANS, and he has completed his MD degree from Central Institute of Psychiatry, Ranchi. He has vast experience of serving in various institutes. To name a few of them are MS Ramaya Medical College, Bengaluru, and ESI Medical College, Bengaluru, and he is also assistant professor in AIMS, New Delhi, and currently he is working as assistant professor NIMHANS since from last 2018. His main area of interest is primary care psychiatry, common mental disorders, and especially telepsychiatry. He has having the credit of lot of publications among the various journals. He has more than 100 articles, including in the very prestigious journals like Lancet Global Health, Schizophrenia Research, Journal of Clinical Psychiatry, and various other journals. He has more than 10 chapters and 10 periodicals as his credits. He has done more than 15 projects as research projects in more than 10 funded projects. His area of interest research are mainly he has very pioneered in giving inputs in digitally driven primary care psychiatry program for primary care doctors. Of course, we are doing the same program over here in this webinar series, and he is an innovator of on consultation training for primary care doctors, medical interns, and psychiatrist residents. He has designed very novel and very innovative STD format. That is, S for stands for see, T stands for try, and do stands for do it yourself. This kind of STD format of training of trainers model, and it has become more popular. And he is a very well-known resource person for various seminars and conferences. He has having the credit of giving delivery of various speeches in more than 100 areas, 100 places. And he has a lot of poster presentation, paper presentation. He was being a resource person in various workshops, symposium, and panel discussion areas. He has been also a very famous and very known guide and mentor for various DM neurology and community psychiatry and psychiatry residents and PhD scholars. And To name very few of the important awards he has been awarded are, he is being the recipient of Mahapatya Award 2020 from Indian Psychiatric Society at ANSIPS 2020 Kolkata. And he has been rightly chosen as best public service initiative in this category. He has been awarded Digital India Summit Award for the project of Karnataka Telepsychiatry Monitoring, Mentoring and Monitoring project. It's very well known and very highly acclaimed project. And he was being a resource person. He was rightly chosen for the best public service initiative in 28th June 2019. And he has also been awarded with Professor R. Raghuram Distinguished Young Teacher Award in the recently conducted 2019 CAMSIPS. And this is about our today's resource person, Dr. N. Manjunath sir. Over to you, sir. And I also request Dr. Kasturi Madam to say a few words about this webinar. Today's chairperson, Dr. Kasturi Madam. Kasturi Madam is around. Karan sir?
Hello.
Yes.
Good evening, sir.
Yeah.
Can you hear me? Yes.
Yes.
I welcome one and all. It's a great pleasure to welcome one and all, and happy Christmas. And on this auspicious day, it's very pleasurable to hear to Dr. Manjunath. Dr. Manjunath will be talking on the primary care in psychiatry. It is very important because the primary care doctors who are the practitioners are the first route entry into the mental health. So this is very important. He'll be dealing with the very normal diseases which you will be encountering in psychiatry. And by this, most of the private practitioners and also in community, most of the mental health diseases can be enrooted, and that can be later referred to psychiatry. It's a very important topic, and it's a great pleasure to listen to Dr. Manjunath and day to Dr. Manjunath. I hand over the mic to Dr. Manjunath.
Thank you very much, madam, and good evening all. And I formally welcome all of you for paid webinar series. Paid means not the money paid. It is a psychiatry academics for IMA doctor with Dr. Bijal has made an acronym for this. And actually today is a third topic. And benefit, I would think, from this paid seminar is to enjoy personal life, family life, to enjoy professional life in a better way, and possible reduction of medical legal cases. And as all of you, at least majority of you know that this is the third webinar series. In October, I spoke on psychiatry for all IMA doctors, means MBBS doctor, how and why. There is a psychiatry is required for all MBBS doctor who are practicing. In November, I spoke about how did we design primary care psychiatry program for practicing doctor. We in this topic, what I spoke is that we are not heavy dependent on the book available in the market for MBBS doctor. We have designed our own curriculum for the course as well as syllabus and delivery method to doctor who can participate from his clinic by seeing the patient in live consultation. That kind of training we have got. We did not want to call any doctors to demands or anything. Maybe a few days, 1 or 2, 3 days. Then remaining 1 year of the course, they will be at their clinic and they will participate from their clinic. And at the end, they will get a diploma. That kind of things which we have worked. And today's topic would be on clinical schedule for psychiatry, which we can simply call it is a syllabus of psychiatry for practicing doctors. And this syllabus, it is what we can call as a point of care manual. Point of care manual means you are sitting in front of patient and in clinic, you just have to just see a few pages and go through it, and you quickly imbibe it. And I would request whenever you want to learn psychiatry, use this schedule, this manual for initial 30 to 40 patients. After that, you don't need to use this thing. I can assure you that way. So only this is very essential for all of you only for initial 30 to 40. patients. Maybe I would suggest to use it for, I always suggest our doctors to use it for only 2 patients per day. So it means in 20 days, you can finish this thing. And after that, you don't need to open it of this. That much I can assure you, because we have made it and there are a lot of feedback. I am MBBS, more than 1,000 MBBS doctors across the country given feedback to prepare this schedule. So I acknowledge their help in designing this schedule. And next, I am proposing another 3 topic from my side is in January, February, and March. For January will be on common mental disorder, which we call as a CMD. And I am sure this is the topic which is helpful for all MBBS doctors. And next in February, I am proposing alcohol and tobacco disorders. And March, it will be severe mental disorder, and which is commonly, which all of you say, psychiatry means some mental illness. Mental illness means psychosis. Psychosis means schizophrenia. All these categories will come in final severe mental disorder. But for real practice of MBBS doctor, these severe mental disorders are not really required. What is required among the psychiatric disorders are common mental disorders, alcohol, and tobacco. So this much, and next 2 topics I will cover. And today's topic I will again go. This is clinical schedule for primary care psychiatry. And this, as I said, this is a syllabus, and it has undergone many versions till now. And this version 1, version 2.0, 2.1, 2.2, 2.3. 2.3 is a COVID version where Dr. Suresh Sir has personally sat and made it for doctors. But I am heavily focusing on today's topic on 2.2 version. And it has been used in many states across the India: Karnataka, Maharashtra, Uttarakhand, Chhattisgarh, Bihar, Telangana, as well as Andhra Pradesh, Tamil Nadu, a few other states. And next is going to be Goa. And as I said in first topic, is that we focus for all MBBS doctor in primary care program is only 6 illness. It is a TAP-SAD illness. TAP-SAD is nothing but tobacco disorder, alcohol disorder, psychotic disorder, somatization disorder, anxiety disorders, and depressive disorders. So, and now I will just go to PDF. Hello. Yeah. Yeah. Now I would just go to this. I'm sure all of you are seeing this.
Yes.
Yes, sir.
Yeah. This is the clinical schedule which we have prepared. This is 2.2 version. And at the beginning, I said this is prepared only for clinical use of primary care physicians. Those who are interested to get for MD entrance and all, it will not helpful. Only for seeing patients and get used to and helping your patient understand what is psychiatry and kind of thing, it will be helpful. And these guidelines, this point of manual guidelines is having guidelines for screening, referral, early diagnosis, first line treatment. What we call primary care psychiatry is nothing but first line treatment. All MBBS doctors should give first line treatment for all these common 6 psychiatric disorder. And if patient improves in couple of weeks, you continue treatment, otherwise send to psychiatrist, refer to psychiatrist. And this manual is meant only for adult patients in outpatient setting. So this is the crux of this curriculum. And we have done a classification of psychiatric disorder for primary care in a different way, which is not available in any books till now. And we have made it a simplified format for the MBBS doctor. And we have made some of the diagnostic criteria changed from standard criteria to very, very simplified criteria. Simplification doesn't mean that there is a quality has reduced. We have made sure the quality is not coming down at any cost, only to make it very simple for doctors to understand and quickly pick up in 2 to 3 minutes consultation. And I think I must say that how I got idea to prepare this smaller manual. One of my friend means he was my MBBS senior, Dr. Venkatesh. He is working in BBMP. One day he happened to meet me at Nimans. He said, Manjunath, ನೀವೆಲ್ಲ ಹೇಳ್ತೀರಾ ಸೈಕ್ಯಾಟ್ರಿನ ಪೇಷಂಟ್ ನೋಡಿ ಅದ್ ಮಾಡಿ ಅಂತ ಹೇಳಿ, ಬಟ್ ನೀವು ಎಲ್ಲಾ ಪೇಷಂಟ್ಗಳು ಎಲ್ಲಾ ಸೈಕ್ಯಾಟ್ರಿ ಡಯಾಗ್ನೋಸ್ ಮಾಡೋದಕ್ಕೆ 5, 10, 20, 30 ನಿಮಿಷ ಅರ್ಧ ಗಂಟೆ ಅಂದ್ಬಿಡ್ತೀರಾ, ಅಲ್ಲಿ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ, ಯಾರು ಮಾಡೋಕ್ಕಾಗಲ್ಲ. If you can design anything to make diagnosis of depression in 2 minutes, I can request all doctors to involve. So that thought was in my mind. So I started thinking from there. And this is the manual which beginning I started from his words. So what are we expecting from general practitioner doctors? In first consultation, they should do rapid screening of all adult psychiatry for possible psychiatric disorder and able to provide first line treatment whenever there is a psychiatric disorder. If no psychiatric disorder, treat on your own the way you are treating. If patient of your psychiatric disorder whom you have given medications and he shows improvement in 2 to 3 weeks, you continue to treat yourself. You don't need to refer to any psychiatrist. If there is no improvement in 2 to 3 weeks, please refer to psychiatrist for further care. And whenever psychiatrists refer to MBBS doctor and then what is the expectation we have from a general practice doctors? And basically, we want doctors to give, whenever we send, we will make sure that patient is completely stabilized only to repeat prescription. It is something like this. BP and sugar, BP and diabetic patients are coming for follow-up and you just write the prescription. When you write prescription, I'm sure you will check some of the common side effect, any worsening is there or anything. If worsening is there, send it to psychiatrist. If no worsening, just check for side effect and repeat prescription. These are the expectations which we have. And especially if patients or family member ask when to stop medication or anything and you are not confident of it, that time you can refer to psychiatrist. And now, what are the kinds of patients who reaches MBBS doctor with psychiatric disorder? But unfortunately, majority of the MBBS doctor doesn't know that these are the psychiatric disorder because we have not been trained properly during our MBBS. That is the attribution. And wherever MBBS doctors writes prescription for all these kind of 6 prescription, there is a psychiatric disorders are very, very high probability. Where you are prescribing analgesics, painkiller, multivitamins in any form, including bottles, tonics, anything, tonic seekers, and energy syrups, antacids or H2 blocker, proton pump inhibitor, you are prescribing. You just omeprazole, if some patient comes and says that an gastric is we just write omeprazole or pantoprazole kind of thing, and we will not think what our medicine Harrison book or Davidson has said how long we have to give. That kind of things has gone up. And benzodiazepine, alprazolam, we are continuously prescribing. Whenever any patient comes and says sleep problem, we'll just prescribe alprazolam or diazepam or whatever thing. And repeatedly, bottle ಕೊಟ್ಬಿಡಿ sir ಅಂತ ಬಂದು ಕೇಳೋರು ಬಹಳ ಜನ patient ಇರ್ತಾರೆ. That is on demand repeated infusion of IV fluid. There is a demand from patient and family member without real clinical need at that point of time. So whenever these kind of 6 prescription which you are writing, please from now onwards think there is a possibility of psychiatric disorder among these kind of patients. Next, whenever how to assess psychiatric disorder. And we are not different from the medical doctors or medical specialists. We, as usual, the way we have been taught in during MBBS, we analyze chief complaints. We have approach of symptom and sign, then make diagnosis and treatment. These are the 4 steps. Among symptoms analysis, we have presenting complaint. We will ask what is the complaint and duration. Then we do brief physical examinations. And at the end of this thing, please think if symptoms and sign, whether can you explain, this is the thing I am just trying to show, can you explain above symptoms and sign with known medical illness? If yes, please proceed the way you are making with your diagnosis and treatment. We have no we don't contradict you if you are confident of your symptom and sign based clinical proper diagnosis. If there is, you are not confident of making proper diagnosis the way we have read during your MBBS, then you think of illness durations. If less than 2 weeks of duration, then probably you can reassure the patient and ask patient to come for follow-up if symptoms are persist. Reassurance means that you have to tell one sentence, important sentence is that these are the problems are not life-threatening problem. And it is a problem, but not life-threatening problem. Maybe it will come down on its own. If it doesn't come down, please visit me again after 1 or 2 weeks. This kind of reassurance you give and send them back. If symptoms are more than 2 weeks and you cannot explain with the way you are read in your medicine, then you think possibility of psychiatric disorder is very, very high. And how to go about with psychiatric symptoms? And I am sure majority of you doctors check with check with comfortably checking how is your sleep and appetite. So we have made it question number 1, how is sleep? Question number 2, how is appetite? Then that is the best first question to enter psychiatric screening questionnaire is, how is your interest in doing your daily work? This is the best question for any MBBS doctor, for any patient you can ask. A few of the doctors say that we never ask you how is your interest in our life. So this is the best question, because once you ask that how is your interest, majority of the doctor patients will feel very comfortable. They think that why these doctors never asked and now is asking, and majority of them very comfortably telling what is their interest. So this is the best opening question for psychiatric assessment. Next comes, as I said, this is a TAP shared 6 illness. If you see right column here, so you see only TAP SADs are there. Based on these diagnoses, we have prepared some screening questionnaire. It is Indianized questionnaire, which is not available in any books or textbook in any other country. It is prepared only for MBBS doctor from NIMANS. So if you think alcohol disorders are there, and we have prepared only 3 questions. In the past year, are you drinking alcohol heavily or regularly? Heavily or regularly? In the past year, are you not getting sleep without alcohol? Are you getting shaking of sand or body whenever you reduce or stop the alcohol? Among these 3 questions, any question which is S, please think of alcohol disorder, and alcohol disorder criteria we have given subsequently. I will go through it little later. Next comes to tobacco. It is only 1 question. Soon after you getting up, within 1 hour of getting up, are you using BD cigarette, tobacco? If it is yes, it's more or less tobacco addiction. So you don't need to do anything further for making diagnosis. Next, coming to panic attacks, panic disorder, we have only 2 questions. In the past few weeks, did you get sudden attacks? ಇದ್ದಕ್ಕಿದ್ದಂಗೆ ಗಾಬರಿ ಆಗೋದು, ಭಯ ಆಗೋದು ಆಗ್ತಾ ಐತೆ ಇತ್ತೀಚೆಗೆ. ಅದು without any reasons. That is a question number 9. Without any reason, are you getting fear or this thing? I am sure all of you in your whole life, you have seen this kind of patient plenty. But probably very rarely you made a diagnosis of panic disorder and properly treated the way evidence-based medicine allows. Okay. Then comes generalized anxiety disorder. In the literature and in our my observation is that this is the commonest psychiatric disorder which goes to MBBS doctor and all MBBS doctors. So how to tap that illness? One best question is that in the past few months, are you getting tense, stressed up with no reason or small trivial reason? Ide yav tara illness irutte anta helidre ನಾವು ಜನರಲಿ ಹೇಳೋದು, ನಾನು I always tell ಟೆನ್ಷನ್ ಪಾರ್ಟಿ ಅಂತ ಹೇಳ್ತಿರ್ತೀವಿ ನಾವು ಫ್ರೆಂಡ್ಸ್ ಫ್ಯಾಮಿಲಿ ಯಾರಾದ್ರೂ ಇರೋರಿಗೆ. ಯಾವಾಗ ನೋಡು ಟೆನ್ಷನ್ ಅಲ್ಲಿ ಇರ್ತಾನೆ ವಿತೌಟ್ ಇವನ್ ರೀಸನ್. ವಿ ನೋ ದಟ್ there is no reason, but for him, even for small reason, he gets tensed up. So this is very important symptoms in 10th. 11, how to think that is abnormal. The next question should be asked, are you unable to control these tension? So this question, if we say yes, it is more, you can think of generalized anxiety disorder, and further criteria of generalized anxiety disorder is the next I will discuss. Then coming to depressive disorder, these 3 questions are there, 12, 13, 14. Among 3, if any one question is yes, please check the criteria of depressive disorder below. Then you think of diagnosis and treatment, that subsequent thing. And I will tell you 3 questions. Have you been feeling tired all the time? This is first question. In the last few months, have you lost interest or pleasure in your regular daily activities? Then the 14th, the third question, in past few weeks, have you been feeling sad or depressed? These 3 questions is enough to make screening of depressive disorder. And in regular our psychiatry textbook, the last question of depressive disorder is always been first in our standard textbook. And why we have made it as a last in this screening question for MBBS doctor is that, and one of the differential diagnoses of depressive disorder is anemia. And when I was doing MBBS, there are a lot of anemia patients were there. Now I think that amount of prevalence has come down, but it's still there. So tiredness is a symptoms of anemia. Then definitely lost interest and pleasure, maybe because of tiredness or anemia, but feeling sad and depressed is one of the classical symptoms of a depression. If any of the 3 are S, then you think of what are the other possible criteria of depressive disorder, which we will see later. Next, coming to very, very interesting illness for all of you, I am sure, somatization disorder. Many times I found MBBS doctor are using the terminology somatization disorder for something like how to make this diagnosis. In the past many months, does this patient have, this is the question you should ask yourself. Does this question have many physical symptoms listed in criteria of somatization disorder below? I'll show you that. Maybe I will show you right now. This is the somatization disorder criteria, 1, 2, 3, 4. If you read this, any of these symptoms persistently present for 6 months, see pain symptoms at multiple sites, gastrointestinal sensation, pain, belching, regurgitation, vomiting, nausea, abnormal skin sensation, itching, burning, tingling, numbing, soreness, or blotchiness, sexual and menstrual complaint, ejaculative problem, hyperemesis of pregnancy, irregular menses, menorrhagia, sexual dysfunction. These are the possible illness of somatization. And there should be, I'm not talking about diagnosis criteria, will come later, but how to make screening questions. I'm going back again, the page number 2. Does this patient have physical symptoms, which symptoms given in the list is, which is unexplainable. Please read this number term, which is unexplainable with current medical knowledge or with depression and anxiety. In past this month, does this patient shows the sign of doctor shopping? And every MBBS doctors are fond of calling the terminology of called doctor shopping is nothing but repeatedly consulting one doctor or many doctors for same problems. So yes, does this patient is complaining, meeting doctors regularly for more than 6 months? Then you can think of somatization disorder. And psychotic disorder is 4 questions we have prepared. It may not be really interesting for you people. I just skip it. Then comes, this is the classificator system which we have prepared for MBBS doctor, very simplified way of classification. I will tell you the basis for making this simple classification, which does not exist in standard psychiatry books, is that all of us, we give paracetamol for all febrile illness, including COVID-19. I'm sure all of you agree with me, irrespective of etiology. So same the thoughts we have used to make this classification system. So here for depression, anxiety disorder, somatization disorder, for all the 3 illness, same medication we give almost. So antidepressant medication is given for all the 3 illness. At the end, a patient who goes to MBBS doctor, there is very few times there is a pure depression, pure anxiety disorder, few somatization. So there is a mixture of depression, anxiety, somatization kind of things. So what we did is the 3 number common mental disorder bar neurosis. If you can think of only that broad category and give antidepressant, that is sufficient. You don't need to think, well, he has some little depressive symptom, he has anxiety symptom, don't worry about it. Because at the end, medications are same. At first line treatment, you give that thing and see whether you respond to patients or not. Then coming to first and second, alcohol disorder, harmful use and addiction. There are 2 categories standard. One, I will just go through it when we call harmful use and addiction later. And tobacco addiction, in 99% of the time in India, when people use tobacco, it is almost used in addiction level only. So using that criteria, especially in clinical population. Okay. Then comes severe mental disorder, psychotic disorder. It's not really interesting, but we have made it that way. Then coming to management, diagnostic guidelines which we are given below. Before, these are based on clusters of symptoms and signs. Our diagnosis is purely based on clusters of symptom and sign. And here we do investigation only for ruling out purpose of other medical illness which will mimic the same symptomatology of their clinical features. In commonly, we do thyroid and cardiac dysfunction could be one of the comorbid or mimicking psychiatric disorders. So we try to rule out with TSH and ECG commonly. And if medical illness is found, priority should be given to treatment of other medical illness rather than psychiatry, if there is a found. Then coming to depressive disorder criteria, core symptoms 3, depressive mood, loss of interest, reduced energy level. There are additional symptom 10 is given. Please go through it whenever you have free time. And at the end, just because symptoms is present today, we cannot make diagnosis. It should be more than 2 weeks. Here, more than 2 criteria of depression, core symptoms, more than 3 of additional 10 symptoms should be available. Okay. And then coming to generalized anxiety disorder, this is nothing but tension party anta ನಾವು ಮಾತಾಡ್ತಿರ್ತೀವಲ್ಲ ಆ ತರ kind of illness, where if you see there are illnesses that the tension, worries or anxiety should be of three characteristics. It should be there. One is generalized in nature, means it should involve many aspects of the person, include family, health, finance, work. ದುಡ್ಡು ಕಡಿಮೆ ಆಗ್ಬಿಟ್ಟಿದೆ, ಏನ್ ಮಾಡೋದು ಮುಂದಿನ ತಿಂಗಳು, ಅದೇನಾಗುತ್ತೆ ಏನೋ, ನನ್ನ ಆರೋಗ್ಯ ಕೆಟ್ಟೋಗಿದೆ, ನನ್ನ ಮಕ್ಳದ್ ಕೆಟ್ಟೋಗಿದೆ, ಈ ತರದ ಯೋಚನೆಗಳು ಬರ್ತಾನೆ ಇರುತ್ತೆ. And they are unable to control. Hello?
Hello.
Yeah.
Hello.
Yeah, madam, can you listen?
Yeah, I'm hearing now.
Yeah. Persistently, it should be present throughout the day. Majority of the time, it should be that tension should be present, and it what we call as technical term free floating anxiety. It is nothing but ಈ ಕಾರಣ ಬಿಟ್ಬಿಟ್ಟು ಸ್ವಲ್ಪ ಹೊತ್ತು ಇದ್ರ ಬಗ್ಗೆ ಯೋಚನೆ ಮಾಡ್ತಾನೆ, ಇನ್ನೊಂದು ಸ್ವಲ್ಪ ಹೊತ್ತು ಬಿಟ್ಟು ಇನ್ನೊಂದೇನೋ ಯೋಚನೆಗಳು ಇರುತ್ತೆ. ಸೊ ದಿಸ್ ಕೈಂಡ್ ಆಫ್ ಕ್ಯಾರೆಕ್ಟರಿಸ್ಟಿಕ್ ಆಫ್ ವರಿ ಶುಡ್ ಬಿ ದೇರ್. And in these kind of patient also present with sleep disturbances, inability to relax, and worrisome headache. The patients comes, and sometimes dizziness also patient comes with dizziness. GAD patients will come. Then coming to panic disorder. Panic disorder should be panic attack. I am sure all of you heard and made thought about it and discussed many times that not all panic attacks can be made as a panic disorder. Panic attack is ಯಾವ್ದಾರ ಅಪ್ಪಿತಪ್ಪಿ ನೀವು ರೋಡಲ್ಲಿ ಹೋಗ್ತಿದ್ರೆ ಇಮಿಡಿಯೇಟ್ ಆಗಿ ಒಂದು ಕಾರ್ ಬಂದು ನಿಂತ್ಕೊಂಡ್ರೆ ನಮಗೆ ಸಡನ್ ಆಗಿ ಆಟ ಎಲ್ಲ ಹೊಡೆಯಕ್ಕೆ ಶುರು ಆಗುತ್ತೆ. ದಟ್ ಈಸ್ ಆಲ್ಸೋ ಪ್ಯಾನಿಕ್ ಅಟ್ಯಾಕ್, ಬಟ್ ದಟ್ ಈಸ್ ನಾಟ್ ಎ ಪ್ಯಾನಿಕ್ ಡಿಸಾರ್ಡರ್. ಪ್ಯಾನಿಕ್ ಡಿಸಾರ್ಡರ್ is a medical illness. So please, is this seeing this should be repetitive. More than one attack should be there. It should be spontaneously occur. ಕಾರ್ ಬಂದು ನಿಲ್ಬೇಕು ಇಮಿಡಿಯೇಟ್ ಆಗಿ ಅಂತ ಏನಿಲ್ಲ. ವಿತೌಟ್ ಎನಿ ರೀಸನ್ these attacks should start. That is the important thing. Without any reason, and it should be unpredictable. You cannot predict when it comes. You can predict when car comes and stops you. I'm sure you get scared, but here unpredictable, spontaneous, repetitive attack should be there. And here this within 10 minutes it should reach abrupt, reach maximum peak, and within another 10 minutes it should come down. So there is some kind of crescendo and decrescendo phase in within 20 minutes. And sudden onset of palpitation, chest pain, difficulty breathing, dizziness, dry mouth, feeling of unreality. And sometimes people will come with, they say that nan satte hogbidtini anta ansutte doctor ಆ ಟೈಮಲ್ಲಿ ಅಂತ. Then another thing is that there is unpredictability is there in these attacks. So unpredictably made people think ಯಾವಾಗ ಬಂದ್ಬಿಡುತ್ತಾನೋ ಭಯ ನನಗೆ ಯಾವಾಗಲೂ ಇರುತ್ತೆ. So these kind of things are there. And these kind of patients, as it is a characteristic, in 10 to 20 minutes it will come down. ಈ ಮಧ್ಯರಾತ್ರಿನಲ್ಲಿ ನಾಕ್ಚುರಲ್ ಪ್ಯಾನಿಕ್ ಅಟ್ಯಾಕ್ಸ್ ಆರ್ ವೆರಿ 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 ಕಾಮನ್. ಮಧ್ಯರಾತ್ರಿನಲ್ಲಿ ಎಮರ್ಜೆನ್ಸಿಗೆ ಡಾಕ್ಟರ್ ಹತ್ರ ಓಡ್ ಬಂದ್ಬಿಡ್ತಾರೆ. ಓಡ್ ಬಂದಾಗ ಪೇಷಂಟ್ ನೀವು ನೋಡಿದಾಗ ಏನಾಗಿದೆ ಅಂದ್ರೆ ಏನು ಇಲ್ಲ ಡಾಕ್ಟರ್, ಈಗ ಮನೆಯಲ್ಲಿ ಬಹಳ ಗಾಬರಿ ಆಗಿ ಹೋಗ್ತಿತ್ತು, ಸತ್ತೇ ಹೋಗ್ಬಿಡ್ತೀನಿ ಅಂತ ಅನಿಸ್ತಿತ್ತು. Because within 20 minutes of traveling from home to your hospital, the panic attacks has come down. And you just reassure after 10 minutes, patient will be calm and you are comfortable. So this kind of situation do occur with the doctor. Somatization disorder, I already explained about these four symptomatology. Important thing is that just because these symptoms present, we don't make diagnosis. It should be at least 6 months symptoms. Doctor shopping should be there. Some amount of dysfunction in their social life should be there. Then coming to psychosis, agitated behavior, bizarre behavior, hallucination, delusion, and these kind of things should be there to make diagnosis. Then coming to alcohol disorder, this is very important for doctors. Whenever I try to explain alcohol disorder, this classification, I always give an example. I had many times doctors are known to have a parties in the weekends. That too, that kind of binge drinking kind of pattern. So if any person who is drinking heavily on weekends, means he has a problematic drinking, which we call as alcohol harmful use, which is frequent type. Infrequent is ವರ್ಷಕ್ಕೊಂದ್ಸರಿನೋ 6 ತಿಂಗಳಿಗೊಂದ್ಸರಿ ಕುಡಿತಾನೆ, ಬಟ್ ಕುಡಿದಾಗೆಲ್ಲ ದಾಂಧಲೆ ಮಾಡ್ತಾರೆ. So that is also problematic. But frequent alcohol used in a weekend heavy drinking is also a problematic drinking. And coming to alcohol addiction, there are if you open a standard book, there are 6-7 criteria given to make diagnosis. We have simplified with only 2 criteria. Does this patient drink alcohol every day, especially in the early morning? And next, this if patient doesn't drink alcohol or reduce the amount of alcohol, does he get withdrawal symptoms in terms of tremor, sleep disturbance, sweating, and palpitation? If both are there, you can confidently make diagnosis of alcohol addiction. and is just go for further treatment of this thing. And tobacco addiction, as I said, in India, the tobacco within 1 hour they have to use it. So this kind of criteria is given. Coming to investigation guidelines, we don't use any investigation and routinely for making diagnosis. As I said, is only for purpose of excluding other possible medical illness which mimic the same symptomatology for patient as approach to you. So in that way, TSS and ECG commonly used investigation by in a psychiatric practice, and CT and MRI of the brain are rarely used in clinical practice, maybe less than 5% of our patients. So coming to treatment guidelines, which please remember these 3 bullet points. In psychiatry, it is not, we have a habit of giving antibiotic for earlier, we used to give 5 days, now it has become reduced 3 days. And please remember, no psychiatric medication will work within 4 days, 5 days. It should be at least 2 to 3 weeks. So onset of action in all psychiatric medication is slow, 2 to 3 weeks. Please, you have to explain to all patients, otherwise they will stop after 3 or 4 days. 2 to 3 days medication, it has no effect on anything of the patient. So please remember, no psychiatric medication. If somebody says, I given medication cure depression in 2 to 3 days, it is just bluffing. It cannot happen in the real practice. And full effect will occur in 1 week, 1 month almost. And we don't stop medication if it is shown improvement in couple of 2-3 weeks. We don't stop medication within 6 months. So we have a longer duration of course of the medication. Something like ATT, you think of ATT in a psychiatry. Definitely don't think of the hypertension and diabetes because it's a lifetime medication. We don't give lifetime, but it's a longer duration. Think in terms of ATT or tubercular type medication, 6 months, 1 year, and meningitis kind of things. It's around 6 months to 1 year. And we don't advise people to stop medication until and unless any other medical emergency is there. Then coming to diagnosis-wise treatment, as we bothered about first-line treatment, this third column is first-line treatment. And this treatment is a broad category which we are given based on the classification which we have made. CMD, predominantly depressive disorder, predominantly anxiety disorder, as I said, it is a trans-diagnostic approach which we are using. All these things are antidepressant medication. SSR is also antidepressant, TC also antidepressant, which I'll just show in the next page. Here benzodiazepine also we use, but we don't use it routinely for a depressive patient. Definitely anxiety disorder, we need benzodiazepine. What kind of benzodiazepine we should use and how to use? If you see this last column, antidepressant SSRI medication is 9 to 12 month course. Benzodiazepine for initial only 2 to 4 weeks. We don't give any benzodiazepine for more than 2 to 4 weeks. Ideally, we should stop in 10 to 15 days, but sometimes we give 2 to 4 weeks, depend upon patient symptoms. If coming to somatization, it is around 2 years treatment, where we give antidepressant, which is a tricyclic antidepressant plus counseling. What kind of counseling? I'll just tell you that can be finished in 1 or 2 minutes. It's not nothing but which it is very long. And as I said, the depression, anxiety, somatization patient who goes to MBBS doctor in especially general practice, it's not a pure illness. Majority of the time you found it, there is a mix in the same patient. So we made a category of mixed disorder where treatment varies. If somatization symptoms are there, prefer TCA antidepressant than SSR antidepressant. It is around 1 to 2 years. Coming to SMD or psychosis, atypical antipsychotic 6 to 9 months. If episodic course episodic psychosis comes, please don't treat yourself until and unless emergency. Please send to psychiatrist, because there are a lot of confusion about the making diagnosis and choosing the medication, especially to mood stabilizer in these conditions. Otherwise, all other illness, we request MBBS doctor to treat yourself, see for 1 or 2 weeks. If improvement continue, otherwise send to psychiatrist. Only in episodic psychosis, if not emergency, send to psychiatrist for their proper diagnosis and a beginning of the medications. Coming to alcohol disorder, as I said, alcohol harmful, not frequent type, where once in 6 months, what you can do? You just counsel them harm of drinking heavily, and maybe if you need plus or minus thiamine medications and send it. And next comes heavy, frequent type of harmful user, weekend drinkers, if you say it that way. there is another typical pattern among doctors and other professionals observed is that whenever they have a party in the evening, they tend to take omeprazole 1 or 2 hours before. So this is also a harmful use of alcohol pattern, where instead of omeprazole, why if really person want to stop it, SYS kind of naltrexone 25 mg half tablet, 25 mg half hourly before drinking session can be used. How it works, I will tell you. Whenever the alcohol sessions are there and you take this tablet half an hour before for 4 or 5 times, then the kick from alcohol you don't get it and you feel like to stopping. So this is medication. Then coming to pure alcohol addiction, anti-craving medication, thiamine supplementation, benzodiazepine detection, which I will explain later. The minimum medication for alcohol addiction should be 9 to 12 months. Then coming to tobacco addiction, the buprenorphine or nicotine replacement therapy 3 to 6 months. Coming to one of the enigmatic and lot of myths about counseling part, especially in the psychiatric patient among MBBS doctor, I would say that counseling is not a consultation. It is counseling. ನೀವು ಫೆರಂಜೈಟಿಸ್ ಪೇಷಂಟ್ ನೋಡಿದ ತಕ್ಷಣ ಒಂದು ಆಂಟಿಬಯೋಟಿಕ್ ಬರ್ಕೊಡ್ತೀರಾ, ಒಂದು ಪ್ಯಾರಾಸಿಟಮಾಲ್ ಬರೆದು ಕೊಟ್ಬಿಟ್ಟು ಅವ್ರ ಪೇಷಂಟ್ ಎಷ್ಟು ನೋಡಿ ಗಂಟ್ಲಲ್ಲಿ ಇನ್ಫೆಕ್ಷನ್ ಆಗಿದೆಯಮ್ಮ, ಈ ಮೆಡಿಕೇಶನ್ ತಗೊಳ್ಳಿ 5 ದಿನ ಆದ್ಮೇಲೆ ಬಂದು ತೋರಿಸಿ. You do, this is also counseling, right? Same thing we also do at psychiatry. Please practice same thing. So it should be very less. What we do is that we say that, oh, ಇದು ನಿಮಗೆ ನಿದ್ದೆ ಬರ್ತಿಲ್ಲ, ಬೇಜಾರಾಗಿದೆ, ಇದು ಒಂದು ಮನಸ್ಸಿಗೆ ಸಂಬಂಧಪಟ್ಟಿರೋ ಕಾಯಿಲೆ. ಮನಸ್ಸಿಗೆ ಮೆಂಟಲ್ ಕಾಯಿಲೆ ಅನ್ನೋ ವರ್ಣ ವಿ ಟ್ರೈ ಟು ಅವಾಯ್ಡ್ ಇಟ್. ಬೀಸೆ ಮನಸ್ಸಿಗೂ ಕಾಯಿಲೆ ಬರುತ್ತೆ, ಶರೀರಕ್ಕೆ ಬಂದ ತರ ಮನಸ್ಸಿಗೂ ಕಾಯಿಲೆ ಬರುತ್ತೆ. ಈ ಮೆಡಿಕೇಶನ್ ಇದು ಮಾತ್ರೆ ತಗೋಬೇಕು, ಕಡಿಮೆ ಆಗುತ್ತೆ, ಗುಣಮುಖ ಆಗುತ್ತೆ. ಬಟ್ ಈ ಮೆಡಿಕೇಶನ್ 6 ತಿಂಗಳು ಒಳಗಡೆ ಯಾವುದೇ ಕಾರಣಕ್ಕೆ ನಿಲ್ಲಿಸಬೇಡಿ. 6 ತಿಂಗಳಿಂದ 9 ತಿಂಗಳು ಹಾಗೆ ಆಗುತ್ತೆ ಮೆಡಿಸಿನ್. ಸೊ ದೀಸ್ ಕೈಂಡ್ ಆಫ್ ಥಿಂಗ್ಸ್ ಸೇಸ್ ಅಂಡ್ ಒಂದು ತಿಂಗಳಿಗೆ ಒಂದ್ಸರಿ ಬಂದು ತೋರಿಸ್ಕೊಂಡು ಹೋಗಿ. So this is the brief counseling which we'll do. If you read this thing, this is the crux of the counseling which is given. As I said, antidepressants, if this is SSRI group of antidepressant, there are 6 group and tricyclic. This only thing is that you may need is best medication. Kandu muchkondu baribeganta antidepressant for patients is sertraline for all category of people, including geriatric, everything. Sertraline is the best. And if you next best is escitalopram, third best goes to fluoxetine, especially in private practice doctors. And if you start sertraline, I see if there is a 3 column, 1, 2, 3. First is initial dose, maximum dose by GPs, maximum dose by psychiatrists. This maximum dose by GPs is not available in any book which I have prepared with after talking to many doctors. Why I prepared, I'll tell you very interesting things. Whenever I tell doctor fluoxetine 20 mg ಶುರು ಮಾಡಿ ಅಂದ್ಕೊಳ್ಳೆ, ಸರ್ 20 mg ಬೇಡ ಸರ್ 5 mg ಶುರು ಮಾಡ್ಬಿಡೋಣ. See, at the end, doctors are also layman whenever you ask us to write the prescription. So what I said is that we use 80 mg per day up to maximum. ಹಾಗಾದ್ರೆ 20 mg ಶುರು ಮಾಡ್ತೀವಿ ಬಿಡಿ ಸರ್. So what I read is that you begin at least with lowest possible dosage. Maybe you, if 2 weeks no response, go to at least half of the dose which we use. If patient still doesn't respond to this maximum dose of GP's dose, then you can refer to psychiatrist. So this is the way. And among these, amitriptyline is the best. I am sure all of you might have used for one or other reason. Rather than isolated medication, you might have given with a combination with so many things are available in the market. So at least 10 mg beginning dose. Maximum dose, we could say that general practice is up to 50 mg. And one of the funny things happen with amitriptyline among all super specialists also, they tend to give at 10 mg even for migraine, many things, including gastroenterologists. 10 mg ಕೊಟ್ಬಿಟ್ಟು ಸುಮ್ಮನಾಗ್ಬಿಡ್ತಾರೆ. ಅದು patients is not really a dose, it is sub-threshold dose. So we would think that at least 25 to 50 mg should be given to the patient to feel some kind of pain threshold symptoms will come down. Otherwise 10 mg ನಲ್ಲಿ ಅಷ್ಟೊಂದು ಇದಾಗಲ್ಲ. Why the 10 mg they are comfortable is my explanation is that this is one of the highly sedative antidepressants. If you give 50 mg on first day, majority of the patients will go knocked down on that day and they get scared and they will come and ask you, sir, ನಾನು ತುಂಬಾನೇ ಜಾಸ್ತಿ ಇದೆ ಬಟ್ ಏನು ಕೊಟ್ಬಿಟ್ರಿ. So the tendency has gone to lowest possible dosage, but we don't know that sedation is the side effect of amitriptyline, which has a tolerance. Means you can slowly increase the dose after 1 week, 10 days up to 50 mg. So crux of amitriptyline use, begin slowly, go slowly with up to the 50 mg. Don't go with first day 50 mg. That is the problem. And coming to side effect, each medication side effect I have explained in the graph here. See, amitriptyline is the highest sedation here. Then coming, I am anticholinergic effect, sexual side effect also there. You can choose among these things. And if you just go through completely, majority of the medications are reasonably comfortable to prescribe for many of your patients. Very rarely the choosing of these antidepressants coming to effectiveness. All medications effect is same. Choosing the best medication is depend upon patient profile and side effect which we don't want in these patients. For example, if I don't want for this patient to have a sedation, then I will not give amitriptyline, and I will go with the fluoxetine. If we go with fluoxetine, we will give this fluoxetine in the early morning because fluoxetine disturbs the sleeps. Okay, so this kind of choosing this thing is there. Then coming to antipsychotic medication, there are common best medication for general practice purposes, olanzapine. Start with 5, 10 mg you go. Don't use more than 10 mg if you are not comfortable, but we use up to 30 mg. So it is your choice. And what are the side effects are there? Olanzapine is sedation is there. So sedation, we use it for a better purpose, especially aggressive patient. If we give olanzapine 10 mg or 20 mg, he will be little sedated and he will be little more comfortable. And there are some side effects, and this antipsychotic depot preparation, which may not be required for you people until unless psychiatrists send you for a follow-up purpose. When that time you need to go through this. And coming to side effect of antipsychotic is this given. If you are interested, go through. And very important for all MBBS doctor, this table we prepared with very lot of difficulties. Please see this table. There are 7 benzodiazepines. I kept alprazolam last, and see this addiction potential. This is the highest addiction potential benzodiazepine. And I am sure majority of MBBS doctors prescribe alprazolam for various reasons. Please think now onwards when you prescribe alprazolam whether I am inducing addiction to these patients, because majority of those patients will come to us after many years of usage, and we find it very difficult to treat. So best medication alternative is a clonazepam. Clonazepam is the first benzodiazepine choice for among the psychiatrists. Why it is? It is a long-acting and addiction potential is very, very low. And coming to alcohol and addiction, tobacco disorder, and I always say that don't expect alcohol and tobacco addiction disorder just do miracle with first one prescription. It cannot happen. It is something like this. Diabetes ಒಂದ್ಸರಿ ಮೆಡಿಕೇಶನ್ ಕೊಟ್ಟ ತಕ್ಷಣ ನೀವು ನಾಳೆ ಕ್ಯೂರ್ ಆಗ್ಬಿಡುತ್ತೆ ಅಂತ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. ಸೊ ಟುಡೇ ಯು ಟೇಕ್ ಕಂಟ್ರೋಲ್ ಆಗಿದೆಯಲ್ಲ ಅಂತ ನೋಡ್ಬೇಕು. ಅಂಡ್ ಐ ಆಲ್ವೇಸ್ ಕಂಪೇರ್ ವಿತ್ ಸಮಥಿಂಗ್ ಲೈಕ್ ದಿಸ್. ಎಷ್ಟು ದಿನ ನಾವು ಬಾಡಿ ಫಿಟ್ ಆಗ್ಬೇಕು ಅಂತ ಎಷ್ಟು ಸರಿ ಯೋಚನೆ ಮಾಡ್ತೀವಿ, ಎಷ್ಟು ಸರಿ ಟ್ರೈ ಮಾಡ್ತೀವಿ, ಎಷ್ಟು ಸರಿ ಓಡಕ್ ನೋಡಿದ್ವಿ, ಮತ್ತೆ ದೆನ್ ಅಗೇನ್ ಫೇಲ್ಸ್. ಸೊ ಹಿಯರ್ patient, there are 3 to 4 times people has to undergo treatment for complete stoppage of alcohol and tobacco. So crux of this thing is that one prescription ಕೊಟ್ಟ ತಕ್ಷಣ ಕಡಿಮೆ ಆಗ್ಬಿಡುತ್ತೆ ಅಂತ ಅನ್ಕೋಬೇಡಿ. First you reduce your expectation, then you can explain to patients better and family member. Coming to this alcohol and this treatment, very important thing is detoxification. I will explain in the last page also how first a prescription should go. And we don't recommend disulfiram to be used by any MBBS doctor, especially at general practice, because of various medical legal issues which is involved with the patients. If you want to use plus use with consent of the patient and complete explanation to the patient, because it may lead to a disulfiram ethanol reaction at any point of patient resumes alcohol. Coming to tobacco addiction, somewhere tobacco nicotine gum is not really palatable to our patient and acceptability is very poor because of the chew perk technique which we have. When you chew perk technique, you put it and chew it, nicotine will get released very, very bitter. The moment the bitter comes, either they spit it or they swallow it, and both is not recommended, because we should allow once it bitter thing comes should be allowed for mucosal absorption. Because it is so bitter, people just spit it or swallow it. So in that case, nicotine is not really helping people. That Best medication in general practice would be bupropion for tobacco stoppage. And varenicline is very, very expensive. It is around 3-month course. It's around 9,000 rupees. And managing psychiatric disorder, comorbid medical illness, diabetes, hypertension, anything. As I said, your reasonably clean medications are there, even with comorbid medical condition. Please use it. Maybe if you are very scared, you go with very low dosage, maintain with only low dosage. If any problem, refer to psychiatrist. In pregnancy itself is one physiological conditions where we would suggest don't take any risk until unless you are really comfortable with psychiatric disorder, refer to psychiatrist. Coming to follow-up, one of the questions we'll ask all doctors is that, sir, follow-up ಹೆಂಗ್ ಮಾಡ್ತೀರಾ ಸರ್ ನೀವು ಅಂತ? I always use pharyngitis ತರಾನೇ 5 ದಿನ ಆದ್ಮೇಲೆ ಬಂದಾಗ ಏನ್ ಮಾಡ್ತೀರಪ್ಪ, ಮುಖ ನೋಡಿದ ತಕ್ಷಣ ನಿಮ್ಗೆ ಒಂದು ಅಂದಾಜು ಬರುತ್ತೆ ಕಡಿಮೆ ಆಗಿದೆಯಲ್ಲ ಅಂತ. ಹೇಗಿದೆಯಪ್ಪ ನೆಕ್ಸ್ಟ್ ಕ್ವಶನ್ ಕೇಳ್ತೀರಾ. ಅವ್ನು ಚೆನ್ನಾಗಿದ್ದಾನೆ, ಎಷ್ಟು ಕಡಿಮೆ ಆಗಿದೆ? ಸುಮಾರು ಕಡಿಮೆ ಆಗಿದೆ ಸರ್, 50 ಭಾಗಕ್ಕೆ ಕಡಿಮೆ. ಸೇಮ್ ಥಿಂಗ್ ವಿ ಡೂ ಆಲ್ಸೋ ಇನ್ psychiatric practice. That can be utilized by you people. See, first question, have you improved with compared to your earlier medication? Yes or no? If no, check whether medication is taken properly or not. ನೀವು ಬರ್ಕೊಟ್ಟಿರದೆ ಒಂದು ತಗೊಳ್ಳದೆ ಒಂದು ಆಗಿರುತ್ತೆ ಬಹಳ ಸರಿ. If it is a wrong way, teach him right way. If right way, refer to psychiatrist. If patient says yes, I am improved, then you think whether he has improved more than 50% or less than 50%. If more than 50% improvement, please continue same dosage for a desirable 6 months to 9 months. If improvement is less than 50%, maybe you can use next higher dosage and ask him to come for follow-up. This is the thing. And coming to addiction follow-up here, if the medication which is available for addiction, anti-craving medication, even if it drinks alcohol and anti-craving medication, nothing will happen generally. So here the crux of the thing is that even if you drink alcohol, don't stop anti-craving medications. I am not talking about disulfiram, I am talking about anti-craving medication of topiramate, baclofen and this thing. Then coming to prescription, please see this is the prescription which we have prepared, template manual. I tell you why. One of the doctor from Uttarakhand has come to us, and when I was seeing patient, I told him to write prescription on my behalf. Then his hand was started shaking. I asked why. Sir, जिंदगी में पहली बार psychiatrist दवा लिख रहा हूँ तो डर लग रहा है. So then I thought that we should train our doctor to write prescription by under our supervision. So this template is prepared with this. So see, fluoxetine 20 mg 100. One benzodiazepine should be given, either clonazepam or diazepam, whichever is available. This is prepared mainly for government doctors. If you have a luxury of writing clonazepam, don't think of diazepam. 0.25 mg tablet 001 10 days, then stop. See, I have written here 10 days only clonazepam. Fluoxetine, counseling to include begin medication. You have to tell them it takes 2 to 3 weeks to begin action, full action 1 month. Come for follow-up after 1 month. You have to tell this. If you are choosing escitalopram, same thing. If you are choosing amitriptyline, see this is the dosage as I said, 25 mg half tablet night for 4 days, 25 mg 1 tablet for next 4 days, then 2 tablet for continue. This is for depression and anxiety disorders. Then coming to somatization disorder, we always prefer amitriptyline from a 12.5 mg dosage to 50 mg. Same thing. And coming to psychosis, as I said, olanzapine or risperidone is the best. When you're using olanzapine, don't use anything. You just plain olanzapine 5 mg 001 for 4 days, then increase to 10 mg. If you are using risperidone, you have to use trihexyphenidyl 2 mg to reduce the side effect of the risperidone. Coming to alcohol addiction, it is at least 3 medications should be given in the prescription for alcohol addiction who comes to you. One is injection optineuron, which has a high dosage of thiamine, 1 ampule. Then comes, it should be given deep IM. Then diazepam dosage, you please see first day dosage of diazepam 112 means 40 mg of diazepam should be given on first 2 days. 40 mg and kuda doctor kuda edurkonbidtare, because many patients even need sometimes 80 mg on first day to control their withdrawal symptoms of the alcohol. And then after every 2 days dose will come down. By 8th day it will be 0. Diazepam will come down to 0 on the 8th day. Then coming to oral B complex medication, counsel the patient and ask him to come for follow-up after 10 days. Then coming to tobacco addiction, here bupropion 150 1 g bare ಬೆಳಗ್ಗೆ ಹೊತ್ತೆ ಕೊಡಬೇಕಾಗುತ್ತೆ, ನೈಟ್ ಅಲ್ಲ. One tablet 100 5 days, then 200 continue. Counseling and follow up every 30 days. Then coming to the course of Diploma Primary Care Psychiatry, the detail of brief summary is given here. And we are hopeful that it will be open up for all MBBS doctors, including government, private, as a regular course at NIMANS very shortly. So coming to this, then next I will just go. I will thank Dr. Madhusudan sir and Bijal, Dr. and other KMA state and IPS KC office bearer for giving this opportunity for us to talk to all the doctors. And I am hopeful that it will be beneficial for every doctor. At least you will pass the message to other doctors that there is psychiatry is required for all the MBBS doctors. Thank you very much.
Sir, I have unmuted everyone.
Questions? Questions?
Yeah.
Any questions?
Yeah. ಯಾರಾದ್ರೂ ಪ್ರಶ್ನೆಗಳಿದ್ರೆ ಕೇಳಿ.
Ganesh.
Very nice presentation, Manjunath sir. You made this primary care among the primary care for psychiatric illness general practitioner very simple. I request our president Dr. Venkatachalapati to say a few words about this presentation.
No, ask questions.
Questions, yeah. Let it.
Yeah. If
let there be a question and answer session, then I can conclude from my side.
Yeah.
Then Kasturi madam, then yourself.
Yeah.
Yes, Ramesh Rao sir. Unmute ಮಾಡ್ಕೊಳ್ಳಿ Ramesh Rao sir.
Yes. Can we get the booklet of this lecture just given now, which contains about 10 pages I observed?
Yes, sir. I have sent a link here in the this chat box, sir. It is available in our website. You can download it. But that.
Okay. Thank you.
And as I said, you please use it only for initial 30 to 40 patients. After that, you don't need. You will get accustomed. And I believe all MBBS doctors are having a very high IQ. With 30 patient usage, it will go to your long-term memory and you can start enjoying your different kind of practice.
Thank you, sir.
Thank you.
Manjunath?
Yes,
Dr.
sir.
Bakle.
Before others asking question.
Dr. Bakle?
Yeah.
Many general practitioners are there. Dr. Maregaudre.
Before others are asking the question, I would like to utilize the time. Manjunath sir, you have advised the people to use risperidone and olanzapine, especially in psychiatric patients, in psychosis. These two medications, risperidone and olanzapine, they are having a very high potential to cause a lipid profile and sugar intolerance, especially glucose intolerance. So people among the participants, I would like to give the caution of be very careful about using this risperidone and olanzapine, especially watch for any kind of metabolic syndrome in these patients before or after starting 1 week.
No, can I respond to you, Dr. Ganesh? I have a different viewpoint. The metabolic syndrome which Dr. Ganesh is talking is more or less similar to the metabolic syndrome appears with OCP pills. So whatever caution you are taking for prescribing OCP pills should also be taken for olanzapine and risperidone. And metabolic syndrome of weight gain and all is a dose-dependent side effect, and what we have given in this schedule is very lower dosage to control the symptoms of the patients. Maybe if there is a symptoms of, as Dr. Ganesh said, if weight gain is more increasing or something like that, please refer to psychiatry. There are other antipsychotic which has less weight gain threshold can be prescribed by psychiatrist later. Yes, Dr. Bijal.
Yeah, actually, with respect to risperidone, myself and Dr. Manjunath sir and along with Jagish Kirtali sir, we did a research in the Thuruvakere Taluka of the rural population. So risperidone, the metabolic syndrome caused by the risperidone is equal to the metabolic syndrome prevalence in the general population. That is what our study finding, what we got through the ICMR study. So that's also my research topic also. my thesis topic. For 6 months follow-up we did, and the metabolic syndrome prevalence was 33%, which is equivalent to the what general population has it. And good lifestyle practices, even were given doses up to 16 milligrams in our rural population. So it's a very safely Risperidone can be used with respect to the metabolic syndrome.
And especially in rural patients, somehow our observation, the metabolic syndrome weight gain at rural population is very, very low compared to urban. And the dosage which if you have seen that schedule, we have asked MBBS doctor to prescribe only up to 4 mg, not more than that. And olanzapine not more than 10 mg. So considering the safe doctor, we want our doctor should be on a safe level on all the ground. And along with that, patient should also get benefit.
Sir, this is Rajendra Sharma.
Yeah,
Hello.
yeah.
Sir,
Yes, please go
I
ahead,
did
sir.
not get from where to get the link, or can you give your email so that we can get
I
this?
will give my email ID. Otherwise, the where it can be downloaded, I sent in the chat box.
Chat box.
And in the
Just verify in the chat box. Yeah, it is there. It is there.
Yeah, or I will send my mail ID also. You can request. I will send you.
Okay, sir. Because I cannot see in chat box. That's what.
Yeah,
No,
it is
I
not
sent
there.
a link here, Dr.
Not there.
Sab.
Yeah,
If
yeah.
you can see here,
It's not there in the chat box.
there is
It
a
is
link.
not
It
there
is
in the
there,
chat
it is
box.
there.
Yeah.
I will send you another time.
First,
See, I am
first
sending now.
mail ಹಾಕಿದ್ದಾರೆ. First
No,
time.
no,
No
soon
problem.
after my email ID, I sent a link.
Fine.
Please send it, sir.
Resend it.
I sent it again.
Okay, okay.
Not at appear.
ಸರ್ ಅದೇನಾಗಿದೆ ಮಂಜುನಾಥ್ ಸರ್,
Yes, sir.
Yeah.
ಎಲ್ಲರಿಗೂ ಕಳಿಸಿ ಸರ್. ನೀವು ಕಳಿಸಿರೋದು ಒಬ್ಬರಿಗೆ ಮಾತ್ರ, ನನಗೆ ಮಾತ್ರ ಬರ್ತಾ ಇದೆ.
Oh, sorry.
ನಮ್ಗೆ ಬರ್ತಾ ಇಲ್ಲ.
Send
to
to everyone.
I am sorry. It's my mistake.
Yeah.
This is the link.
Everyone.
And,
Yes.
it is
Fine,
my
fine,
mistake.
fine. Yes.
Fine. Now it has come. Okay, thank you.
Right.
And my mail ID also I am sharing. Sorry, I think
Okay.
I was sending only to Dr. Madhusudan. My mistake.
Right.
Yeah.
ಬಿಜ್ಜಳರೆ ಮಂಗಳ ಹಾಡುವ.
Any questions? Any further questions?
ಅಲ್ಲ
Sir, ಇದು ಕಸ್ತೂರಿ ಮೇಡಮ್, ಕಸ್ತೂರಿ ನಂತರದಲ್ಲಿ ತಾವು ಮತ್ತು ವೆಂಕಟಾಚಲಪತಿ ಸರ್.
ಸರ್ ಒಂದು ಪ್ರಶ್ನೆ ಇಲ್ಲಿ
ಹೇಳಿ,
ಕೇಳಿಸುತ್ತಲ್ಲ,
ಕೇಳ್ತಾ ಇದೆ ಮಧು.
ಟಿವಿಗಳಲ್ಲೆಲ್ಲ ಇತ್ತೀಚೆಗೆ ಈ ಎಸ್ಪೆಷಲಿ ತೆಲುಗು ಚಾನೆಲ್ಗಳಲ್ಲಿ ಈ ಡಿ ಅಡಿಕ್ಷನ್ ಬಗ್ಗೆ ತುಂಬಾ ಈಸಿಯಾಗಿ ರೋಗಿಗಳಿಗೆ ಗೊತ್ತಿಲ್ಲಾರ್ದೇನೆ ಅವ್ರು ತಿನ್ನೋ ಆಹಾರದಲ್ಲಿ, ನೀರಲ್ಲಿ ಔಷಧಿನ ಕೊಟ್ಟು ತುಂಬಾ ಈಸಿಯಾಗಿ ಆ ಡಿ ಮಾಡ್ಬಿಡೋದು ಅನ್ನೋದು ಒಂದಿಷ್ಟು ಪ್ರಚಲಿತದಲ್ಲಿದೆ, ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಬರ್ತದೆ. ಇದ್ರ ಬಗ್ಗೆ ವಾಟ್ ಆರ್ ದ ಕಂಟೆಂಟ್ಸ್? ಇಸ್ ಇಟ್ ರಿಯಲಿ ಹ್ಯಾಪನಿಂಗ್?
Yeah, I think I will share you my personal experience. Many of the time this is a disulfiram.
Yeah.
Disulfiram is given by family member, and I don't know how family member gets. I am sure it is available in the market and some quacks or whoever is prescribed, or maybe they go to some medical shop, they will ask that drinks madadne matre kodi andre disulfiram kotbidtare. And many of the other quacks may be using disulfiram in a powder format. So they are giving to family member, they are using it. And as we are bound with medical ethics according to our NMC, and we cannot give, and these family member give it, mix in the food and give it to them without knowledge of the patient. And we don't recommend for giving patients these medication without their knowledge. As I said, there are a lot of medical legal complication, and I'll tell you, few of the patient who has been given these kind of medications without their knowledge has landed up to us with many bigger problem with side effect. One of the patient has come with the hemiplegia, complete hemiplegia, and I have reported in the journal also. And he was just some patient has come with the harshness of voice, and I was telling talk properly. Then I asked family member, ಏನಾಗಿದೆಯಮ್ಮ, ಏನ್ ಕೊಟ್ಟಿದ್ದೀರಾ ಸರ್? ಅವ್ರು ಗೊತ್ತಿಲ್ಲದೆ ಮಾತ್ರ ಕೊಟ್ಬಿಟ್ಟಿದೆ. So these kind of things we don't recommend that thing, and but this is a aversive medication. If people use alcohol with these medications, it's known to cause reactions. We don't use. But as I said, other medication, anticraving, topiramate is there, baclofen is there, acamprosate is there. These are the medication is very, very friendly for all MBBS doctors, which can be used from the day one. And how it works, I'll tell you. That it is name itself is anti-craving, that ಕುಡಿಬೇಕು ಅಂತ ತಲಾಬು ಎಳಿತಾ ಇರ್ತದಲ್ಲ ಅದೆಲ್ಲ ಕಡಿಮೆ ಆಗುತ್ತೆ ಇದರಿಂದ. So that medication, and even if patient drinks alcohol with these medication, no reaction do occur. This is one of the best way of starting addiction treatment. But Madhusudan sir, definitely we don't advise disulfiram to give in any form.
ಅಲ್ಲಲ್ಲ, ಈ ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಬರ್ತಾ ಇದೆ ಸರ್, ಆಲ್ಕೋ ಫ್ರೀ ಅಂತ ಬರ್ತಾ ಇದೆ ಒಂದು. ಇಟ್ ಹಸ್ ಬಿಕಮ್ ಎ ನ್ಯೂಸೆನ್ಸ್ ಇನ್ ದ ತೆಲುಗು ಚಾನೆಲ್ಸ್.
ಡಾಕ್ಟರ್ ಮಧುಸೂದನ್ ರೇ, ಅದು ಡೆಫಿನೆಟ್ಲಿ ಇಟ್ ಕಮ್ಸ್ ಅಂಡರ್ ಕ್ವಾಕರಿ. ಓಕೆ, ಇಟ್ ಇಸ್ ಕ್ವಾಕರಿ, ಡೋಂಗಿ. ಈಗ ಕೆಲವರು ಆಸ್ಮಾ ಕ್ಯೂರ್ ಮಾಡ್ತೇವೆ ಅಂತೇಳಿ ಸ್ಟಿರಾಯ್ಡ್ ಮಾಸ್ಕ್ಡ್ ರೂಪದಲ್ಲಿ ಕೊಡ್ತಾರಲ್ಲ, ಅದೇ ರೀತಿಯಲ್ಲಿ ವೆರಿ ಡೇಂಜರಸ್, ಪೆರಿಲಸ್, ವೆರಿ ಡೇಂಜರಸ್. ಅದಕ್ಕೆ ಏನಾದ್ರು ನಾವು IMA ಅವರು ತಗೋಬೇಕು ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ. ಏನಾದ್ರು ಸಮಥಿಂಗ್
ನಿಮ್ಯಾನ್ಸರ್ ತಗೊಂಡ್ರೆ ಒಳ್ಳೇದು ಅನ್ಸುತ್ತೆ. ಬಿಕಾಸ್ ದೇ ಆರ್ ದಿ ಅಥಾರಿಟಿ ಅಂತ
ಜಾಯಿನ್ ಆಗುವ. ಓಕೆ, ಇಟ್ ಇಸ್ ಎ ಗುಡ್ ಪಾಯಿಂಟ್ ಯು ಹ್ಯಾವ್ ರೈಸ್ಡ್.
ಎಸ್ ಸರ್. ಮೋಸ್ಟ್ಲಿ ನೀವು ಇಷ್ಟು ಈಸಿಯಾಗಿ ಮೆಡಿಕೇಶನ್ಸ್ ಕೊಟ್ಬಿಟ್ರೆ ಅಬಕಾರಿ ಇಲಾಖೆಯವರು ನಿಮ್ಮಲ್ಲಿ ತರಾಟೆ ತಗೋತಾರೆ.
ಅಲ್ಲ, ಅವ್ರಿಗೆ ಫಾಯ್ದೆ ಇದೆ ಇದರಲ್ಲಿ, ಮತ್ತೆ ಹೇಳ್ತಾರೆ ನಿಮ್ಗೆ ನಿಧಾನದಲ್ಲಿ. ಇನ್ನು ಈಗ
ಓಕೆ ಸರ್, ಡನ್. ಓಕೆ, ಗೋ ಅಹೆಡ್, ಲೆಟ್ ಅಸ್ ಗೋ ಅಹೆಡ್.
ಓಕೆ, ರೈಟ್. ಬಿಜ್ಜಳರೆ,
ಕ್ಯಾನ್ ವಿ ಕನ್ಕ್ಲೂಡ್?
ಕಾರಣ ಸರ್ ಮೈನ ಮಾತಾಡ್ಬೇಕಲ್ಲ.
ಏನಿಲ್ಲ, ಅಲ್ಲ ಗಣೇಶ್ ಪ್ರಸಾದ್ರು ನನಗೊಂದು ಅವಕಾಶ ಕೊಟ್ರಿ, ತೊಂದ್ರೆ ಇಲ್ಲ, ಏನಿಲ್ಲ, ಮಾತಾಡ್ಲಿಕ್ಕೆ ಅಂತ ಇಲ್ಲ. ನಾನು ಬಹಳ ಖುಷಿ ಆದ್ದೇನಂದ್ರೆ ಇದು 3ನೇ ಸರ್ತಿ ನಾನು ಮಂಜುನಾಥ್ರ ಭಾಷಣವನ್ನ ಇದನ್ನ ಟಾಕ್ ಅನ್ನ ಕೇಳ್ತಾ ಇರೋದು. ಅಲ್ಲಲ್ಲ, though I am a psychiatrist, I am very much impressed the way he has reached the grassroots, that is MBBS doctors.
Thank you, sir.
I am a psychiatrist, and as a psychiatrist I definitely watch for it. It has reached, and in the now March, February ಎಲ್ಲದಕ್ಕೂ ಕಾಯ್ತಾ ಇರ್ತೇವೆ. ಇನ್ನು ಮುಂದಿನ ದಿನಗಳಲ್ಲಿ ಚಂದದಲ್ಲಿ ಬರ್ತೀರಿ. Thank you very much.
And next session will be very interesting for all of you, and we will come with a bit different kind of presentation. Thank you very much, sir.
Okay, thank you, sir.
Madam, Kasturi madam, chairperson.
Yes.
ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ ಮೇಡಮ್.
Unmute.
Hello.
ಹೇಳಿ ಮೇಡಮ್,
ಹೇಳಿ, ಕೇಳಿಸುತ್ತೆ.
Thank you very much, Dr. Manjunath sir. To sum up, sir has spoken about the ಕನ್ನಡದಲ್ಲಿ ಹೇಳ್ಬೇಕಾದ್ರೆ ಮಧು, ಮಾದಕ ವಸ್ತು, ಖಿನ್ನತೆ ಮತ್ತು ತೀವ್ರವಾದ ಮಾನಸಿಕ ಕಾಯಿಲೆ ಇದ್ರ ಬಗ್ಗೆ ಎಲ್ಲಾನು ಚರ್ಚೆ ಮಾಡಿದ್ರು. ಅದ್ರ ಬಗ್ಗೆ ಇಲ್ಲದ್ರಾದ್ರೆ ಮತ್ತೆ ಔಷಧಿಗಳು ಯಾವ ತರ ಕೊಡ್ಬೇಕು, ಪ್ರೈಮರಿ ಕೇರ್ ಅಲ್ಲಿ ನೀವು ಯಾವ ತರ ಬಳಸ್ಬೇಕು, ಮತ್ತೆ ನಿಮ್ಮ ಕ್ವೆಶ್ಚನ್ಸ್ ಸಹ ಆನ್ಸರ್ ಮಾಡಿದ. ನಿಮ್ಗೆ ಏನಾದ್ರೂ ಕ್ವೆಶ್ಚನ್ಸ್ ಇದ್ರೆ ಖಂಡಿತವಾಗಿ ಅವ್ರ ಮೇಲ್ಗೆ ನೀವು ಬಳಸಬಹುದು. ಮೇಲ್ ಅಲ್ಲಿ ನಿಮ್ ಕ್ವೆಶ್ಚನ್ಸ್ ಕೊಟ್ರೆ ಖಂಡಿತವಾಗಿ ಅದನ್ನ ಮುಂದುವರಿಸ್ತಾರೆ. ಇದರಿಂದ ಅವರು ಇಷ್ಟೊಂದು ಸ್ವಚ್ಛವಾಗಿ ಎಲ್ಲರ ಬಗ್ಗೆ ಎಲ್ಲ ಕ್ವೆಶ್ಚನ್ಸ್ಗೆ ಆನ್ಸರ್ ಮಾಡಿದ್ರಿಂದ ನಮ್ಮ ಪರವಾಗಿ, IMA ಪರವಾಗಿ ಧನ್ಯವಾದ ಬಳಸ್ತಾ ಇದ್ದೀವಿ. ಮುಂದೆ ಇದು ನಡೆಯೋದ್ರಿಂದ ನಮ್ಮೆಲ್ಲರಿಗೂ ಹೆಮ್ಮೆ ಆಗ್ತಾ ಇದೆ. ಖಂಡಿತವಾಗಿ he will proceed with all these 5 things. Thank you very much, and I think we have summed up, and any question it will be revert back to Dr. Manjunath. Thank you so much.
Thank you, madam. Good night.
And thank you to the organizers.
President sir.
Good night, sir.
President sir.
Sir. Yes, sir. Good evening, everybody. It was indeed a fantastic talk by Dr. Manjunath, and especially the very nice comparison with the physical diseases like pharyngitis. So we did not get ourselves a kind of skepticism in addressing the mental issues. We can always talk to the patient, address them as we talk to the patient with a physical disease. That was a very important comparison that he made, and we can apply it to our day-to-day practice. And I take this opportunity to thank the speaker, the Karnataka Psychiatric Society Karnataka chapter, and also the NIMMANS faculty for joining hands with IMA Karnataka State in bringing out these monthly series webinars. Third one, which was very successful, and many of them have participated. And very important thing what I want to share here is, and because I am touring the state, and wherever I go, this has made a mark, and especially the mental Vaidya Mano Sahaya Vani, that has become a rage amongst the IMA members, and many of them are very happy that IMA along with Psychiatric Society Karnataka chapter with NIMANS has taken up a very important issue at a very crucial juncture. And before I could conclude, I thank all the stakeholders here and all the organizers, and particularly Dr. Madhusudan, who was the one who initiated the whole process of this webinar series. And I'm happy to announce that Dr. Madhusudan was declared the best president at the National Conference of Indian Medical Association. And I am also happy to state that there was a Presidential Appreciation Award given to our secretary, past secretary, Dr. Srinivas. So not only the office bearers, almost 10 doctors of Karnataka have been awarded as the best doctors for their very wonderful work because of the corona. So they're all doing wonderful job, and they are the frontline warriors taking care of corona patients. So 10 doctors have been awarded by the IMA headquarters, Delhi. So that is a very important and a very happy moment for IMA Karnataka. So before I could conclude, I take this opportunity to wish each one of you a very, very happy New Year, and see you all in the month of January. Good night.
Thank you, sir.
Yes, sir.
Thank
Yes,
you,
sir. Happy
Mr.
Christmas and Happy New Year to all of you.
Christmas and
Thank
Happy
Thank
New
you,
Year
sir.
in
Happy
advance.
New Year for all of
So
you.
meet you in the next year.
Yes, sir.
Happy New Year.
ಹೊಸ ವರ್ಷದಲ್ಲಿ
ಹೊಸ ವರ್ಷದಲ್ಲಿ ಮತ್ತೊಮ್ಮೆ
ವರ್ಷದಲ್ಲಿ
ಹೊಸತನದೊಂದಿಗೆ
ಹೊಸ ಹೊಸ ಕಾರ್ಯಕ್ರಮಗಳ ಜೊತೆಗೆ
ರಿಯಲ್ ಪಿಕ್ಚರ್ ಶುರು ಆಗೋ ಸೆಕೆಂಡ್ ನೆಕ್ಸ್ಟ್ ಇಯರ್ ಇಂದಾನೆ.
ಎಸ್ ಸರ್, ಎಸ್ ಸರ್.
ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್ ಮುದ್ರಾಜೆ.
ಸರ್,
ಥ್ಯಾಂಕ್ ಯು ಗಣೇಶ್. ಗಣೇಶ್
ಒಂದೇ ಮಾತು
ಹೇಳಿ.
ನ್ಯೂ ಇಯರ್ ಬರ್ತಿದೆ ಅಂತ ಹೇಳಿದ್ರೆ ಪಾರ್ಟಿಯಲ್ಲಿ ಜಾಸ್ತಿ ಅಬ್ಯೂಸ್ ಮಾಡೋ ಪೊಟೆನ್ಶಿಯಲ್ ಇರೋರೆಲ್ಲ ನಾಲ್ಟ್ರಾಕ್ಸನ್ ತಗೊಳ್ಳಿ ಅಂತ ಮಂಜುನಾಥ್ ಸರ್ ಆಲ್ರೆಡಿ ಹೇಳ್ಬಿಟ್ಟಿದ್ದಾರೆ.
ಯಾರು
ಒಂದೇ ದಿನ ತಗೊಳ್ಳೋರಿಗೆ ನಾನು ಏನು ಹೇಳಿಲ್ಲ.